Good afternoon, everyone. I wanted to present one of my objectives for my postdoctoral fellowship. Last year, I presented one of the objectives, which was focusing on the immunophenotype and activation of cells in the CSF after patients with cryptococcal meningitis had initiated antiretroviral therapy. And so sort of following up from the last presentation, we're switching from bacteria to fungi. And this particular study was focusing on looking at the immunomodulatory effects of adjunctive sertraline therapy. And I have to say that this was in the context of a clinical trial that was conducted between 2017, mid-2016 and mid-2018, in which patients who had cryptococcal meningitis were randomized to either adjunctive sertraline or standard of care therapy. So I will quickly do an introduction and then tell you a little bit about this sertraline story and what other prior studies have shown, and I'll also tell you a little bit about what I found and then the next steps. So the annual incidence of cryptococcal infection remains a significant problem, although there are huge numbers of patients obviously who have bacterial meningitis in the meningitis belt. Sub-Saharan Africa still suffers the brunt of cryptococcal meningitis, and if you just look at Uganda somewhere down there, East Africa with the orange, is that orange? Yes. It's about an estimated 15 to 25,000 cases annually. And this is both just cryptococcal disease, which is asymptomatic, as well as cryptococcal meningitis. And overall, the data now suggests that there are about 180,000 deaths due to cryptococcal meningitis in Sub-Saharan Africa. A few years ago, a group in Texas looked at repurposing of selective serotonin reuptake inhibitors for Cryptococcus. And this was an incidental finding in which patients, women who were on antidepressants and specifically sertraline, were coming in with fewer and fewer episodes of vulvovaginal candidiasis. And so somebody thought, perhaps sertraline is doing something. And so looking at the studies that they did, they showed that, and this was replicated in different studies, that sertraline had in vitro fungicidal activity against Cryptococcus neoformans, which was synergistic to fluconazole. So most potent antifungal effects were also observed in mice that were treated with sertraline and fluconazole combination therapy. However, when we moved this into a phase 3 clinical trial, where we were basically giving, as I mentioned earlier, randomizing patients to sertraline in addition to their antifungal therapy. This is what we found, that those who were in the sertraline group, had about 52% mortality compared to those who were on placebo, and that was about 46%. So eventually what we concluded is that sertraline did not really reduce mortality among patients with HIV-associated cryptococcal meningitis. Prior to this phase 3 clinical trial, we had also done a phase 2, which interestingly had demonstrated that the clearance of the fungus from the CSF was fairly good when we added sertraline to regular antifungal therapy. And in other data that other people have looked at, antidepressants have been shown to have negative immunoregulatory effects, and it's now thought that people who have depressive illness because they're having some sort of problem with their inflammation. And so people have looked at studies including sertraline, trazodone, and clomipramine, which have shown significant suppressive effect on interferon interferon gamma, and they also think that those drugs facilitate the increased production of interleukin-10, which is a negative immunoregulatory cytokine. Other studies have also shown the beneficial anti-inflammatory effects of sertraline in a murine model of arthritis, and Horikawa and others also suggested that sertraline may inhibit microglial activation by inhibiting interferon gamma-induced elevation of intracellular calcium. And so the other potential mechanism is inhibiting this microglial TNF and nitric oxide production. So based on this data, I basically designed experiments to, one, determine if individuals who were receiving adjunctive sertraline with fluconazole had decreased monocyte inflammation as well as chronic T-cell activation when compared to those who were receiving fluconazole alone. So this is sort of, later on in their antifungal treatment. And the other objective was to determine whether the expression of intracellular interferon gamma, IL-17 and IL-10 from T cells, and TNF and IL-6 from monocytes was modulated by adjunctive sertraline. And this was going to be after stimulation with cryptococcal antigen or the mitogens like the polysaccharide or Staphylococcus enterotoxically. So in terms of, very briefly with the methods, so we had about 11 patients who had cryptococcal meningitis and had been on adjunctive therapy with sertraline, and they were matched in age, based on age, CD4 and gender, to 11 patients who were only receiving fluconazole during the consolidation therapy. And for those who were receiving only fluconazole, this was a historical cohort. Again, these were samples that had been stored from a previous clinical trial. And so these archived peripheral blood mononuclear cells have been archived at 4 weeks and at 8 weeks of their cryptococcal therapy. The basic comparison was taking those who were on sertraline and fluconazole, 4 weeks and 8 weeks of their consolidation therapy, to look at CD69 and CD163 expression, which are really markers of monocyte activation, and also looking at CD38 and HLA-DR, which were expressed on T cells. And the other comparison was looking at IL-6 and TNF-alpha, again pro-inflammatory cytokines that are expressed by monocytes, and interferon gamma, IL-17 and IL-10 expressed by CD4 and CD8 T cells, and basically comparing the two groups at both time points. What I'm going to highlight is, first of all, how we determined which were the T cells, CD4 T cells, CD8 T cells, and what cytokines they were producing. This is basically just a gating strategy, and this shows which cells were activated. So the focus was on activated T cells expressing both HLA-DR and CD38 in that second quadrant, and then looking at the expression of IL-10, interferon gamma, and IL-17 from those cells. And for the monocytes, essentially what we did is determine the general gate for monocytes, and then look at CD4 low expression and CD3 negative T cells. We then looked at the expression of CD14 and CD16, and then the expression of cytokines TNF-alpha and IL-6. And then for the activation, the co-expression of CD69 and CD163, which is in that second quadrant, and then looking at the expression of TNF and IL-6 from those cells. In terms of the results, this is really just a comparison of the sertraline group and the fluconazole group. What was notable perhaps was the higher CSF quantitative counts in the sertraline group compared to the group that was only on fluconazole. And the other variables were really almost similar. I'll just quickly run through what we found. This is just a summary of some of the results. In looking at the frequency of activated T cells, we didn't really find any difference in the T cell activation. And so this is the group who were on adjunctive sertraline, and that's a group who were on fluconazole. And looking at the CD4 T cells, with the black bar showing the median cells, there was really no difference between CD4 and CD8 T cells. When we looked at the expression of IL-10 from CD8 T cells at week 4 of antifungal therapy, what we found was when we stimulated with mitogen SEB, there was a higher, close to significant, well, not a very significant p-value, but we certainly found that the median expression of IL-10 was slightly higher in the group that was on adjunctive sertraline, which seems to be in sync with what other people have shown previously. When we looked at activated CD4 T cells, there was a similar finding, and the bar for the median is just above the 0. And you don't see 11 points here because the negative responses were all sort of considered as 0. And so this result is again almost similar with higher IL-10 from CD4 T cells. When we looked at interferon gamma, we found that the group that was receiving sertraline had suppressed interferon gamma expression. This was at a later time point of week 8 in their antifungal therapy. And again, this seems to be in line with what other people have shown. The IL-6 expression, on the other hand, from activated monocytes was different from what we had thought. It seemed to be higher among those who were receiving sertraline, and that was not quite what we expected. And similarly, when we looked at IL-6 from activated intermediate monocytes, which are known to be more pro-inflammatory, again, we found a similar result with borderline p-value suggesting that those who were on sertraline were producing more IL-6. So, of course, a couple of limitations. This was only a pilot comparison with a small sample size, which could preclude any conclusions about the differences that we observed. And then the other question was whether there was the lack of cryptococcal specific responses may have resulted from the type of antigen that we use to stimulate the cells. So this data suggests that mitogen-specific T cell and that there is mitogen-specific T cell and monocyte cytokine modulation. Prior studies have shown that mitogen-specific responses occur with inhibition of Th1 cytokines. What was different here was that we didn't find a similar result with the monocytes. There was no modulation to cryptococcal antigen-specific responses that was observed, and so potentially we don't think there's any impact on cryptococcal-specific responses by sertraline, and we also found that there was a variability in responses, which seemed to be dissimilar to previous data. In conclusion, these findings, although from a small sample size, confirm that there's increased IL-10 expression. In other words, sertraline possibly induces negative inhibitory responses among patients who are on sertraline around week 8 of their antifungal therapy. And this effect is likely increased with prolonged exposure to sertraline because we didn't find any differences at week 4. The pro-inflammatory expression of interferon gamma was inhibited among those who were on sertraline versus fluconazole. The cytokine production of IL-6 by monocytes showed this reversed pattern, which was not similar to what others have found. We think there's a possible difference in the mechanisms of sertraline. If you look at, sort of compare what the effect is on adaptive versus innate immune systems. These results, because we found negative results from the main clinical trial, it's also possible that there's really no impact as far as cryptococcal disease is concerned. However, these results definitely suggest that there are cytokine changes that could be induced by sertraline among patients who have depressive illness. And so the next steps, hopefully as I continue to thrive, while I've applied for Senior EDCT Fellowship, which is really going to, well, the idea is to look at a randomized trial to determine outcomes of interrupting or continuing ART in patients who have unmasking cryptococcal meningitis after recent ART initiation. I'll be leading a couple of clinical trials, TB meningitis, and oral amphotericin, as well as a new oral antifungal, APX001. And then another trial that's looking at liposomal amphotericin for asymptomatic antigenemia. And then a phase 1/2 of a new anti-HIV peptide, as well as completing a multi-site trial that's ongoing with the use of single-dose liposomal amphotericin versus standard of care, the Ambition trial. And I continue to provide mentorship for 3 PhD students and 3 master's students, as well as 2 EDCT fellows. As I close out my postdoctoral fellowship, I am certainly grateful to Professor Soan Kambo, who has, as I mentioned, he's been successful because I think he continues to help other people to succeed. And I believe that Thrive is, hopefully, there will be a Thrive 3.0. And many more fellows will certainly have the exposure, I think, that will develop scientists in Africa. So thank you very much.